Hello everyone, my name is Lina Chrysostimo and I will be presenting my research on LCAT deficiency. To begin, what is LCAT? LCAT is a gene instructor for making an enzyme. LCAT esterifies cholesterol in plasma thanks to this reaction. Unesterified cholesterol becomes esterified, and this process plays a role in removing cholesterol from the blood and the tissues by a process called reverse transport cholesterol transport. What is LCAT deficiency? LCAT deficiency is a very rare genetic disease that needs two mutated LCAT alleles, this being a recessive disease. The mutation impairs the enzyme's ability to esterify cholesterol and lipoproteins. Impairments of this mechanism for reducing cholesterol in the body leads to cholesterol deposits in the corneas, kidneys, tissues, and organs. Subjects with two mutated alleles can develop two different syndromes that are characterized by different signs and symptoms. The first we have is the fish eye disease, FED, and it entails the corneal opacity, low HDL, anemia, and cardiovascular disease. The second syndrome we have is familial LCAT deficiency, also known as FLD, which has the corneal opacity, and the biggest difference is that this one includes the renal disease. It also has low HDL, anemia, and cardiovascular disease. The renal disease is what makes this type of this form of the disease more severe. For both, cardiovascular disease has a question mark because it is controversial. The goal of this study is to know why some people develop the most severe form of the disease, which is familial LCAT deficiency, and others do not, and which parameters are different in FED and FLD versus heterozygotes versus normal subjects. For our methods, we searched all the papers that described the disease, extracted information, annotated it into a database, and looked at the possible differences between healthy individuals and individuals with milder FED or severe FLD, and then we summarized these findings. When looking at the clinical signs of this disease, we see that in corneal opacity, that both FED and FLD have this symptom and most heterozygotes don't. For renal disease, we see a difference that subjects with FED and who are heterozygotes do not have renal disease. The majority of the renal disease happens in FLD subjects. Now looking at the lipid profile, when we look at the HDL cholesterol, we see that FED and FLD are very similar levels. They both are very low compared to the heterozygotes and the control group, both being different from those two factors. With this, we can say that FED and FLD both have the symptoms of low HDL cholesterol, which is not a preferable factor to weigh in when trying to diagnose a patient with FED or FLD. When we look at the unesterified cholesterol, we see a very big difference between the FED and the FLD. FLD being very high and being very different from the heterozygotes and control groups, but the FED being similar to those groups, since we see a big difference. We can concur that a patient who has very high unesterified cholesterol, the patient has a high chance of having familial LCAT deficiency instead of the milder form, fish eye disease, also known as FED. So in conclusion, FLD is the most severe form of disease, and it is characterized by the development of renal disease. UC is higher in FLD compared to FED. These data suggest that UC may be a suitable biomarker to predict the FLD clinical diagnosis. This concludes the presentation. Thank you to the APSA Virtual Summer Research Program and to my mentors, Dr. Cecilia Vitale and Dr. Marina Cuccio, for this amazing opportunity and great honor. Thank you again.